Yeah, but Dr.
I'm just telling you interesting case of thyroid as we're talking about thyroid. I thought your sub-centimetric lesion you can get like that.
But Dr. Morwani,
Yeah.
if it was a metastatic lesion,
Yeah.
why was radioiodine therapy not considered?
No, the radioactive therapy was considered, na. But get rid of disease and then give radioactive, supplement it, not as a primary therapy. Get rid of disease and give radioactive therapy then. If you have CA thyroid today, what is you going to do? What is your treatment?
But was
You
that
are going to look after the CA thyroid and then give whatever you want to give. You
Okay.
understand what I'm saying?
Okay, okay.
Radioiodine is I-31 is not a solitary treatment for the CA thyroid. Does anybody give? Does anybody, Satish? Does anybody give only radioiodine for CA thyroid?
No,
For
but
CA thyroid,
no,
the
but
treatment will be
no, for this case.
thyroidectomy plus I-131.
No, sir.
Not always.
Hello.
Now, if-
Indication for iodine 130.
no, no,
Hello.
but you cannot give only I-31 for the CA thyroid.
No. What I
kind
mean
of
to
CA
say,
thyroid? You're taking using such a broad term.
can't hear.
You should give only I-131 only inserting surgery.
No. If you want me to answer, if you want me to answer,
Follicular carcinoma.
yeah, the well-differentiated thyroid cancers are iodine avid. The rest are not iodine avid. There's no point in discussing all that. The medullary, undifferentiated, hurdle cell, anaplasty, they don't concentrate the iodine. So only the well-differentiated concentrate the iodine, number one. Now in well-differentiated, there are indications for using the radioiodine, not in every case.
Yeah, but what is the primary treatment? You will do only radioiodine?
Yes, not radioiodine, not giving. First we'll get a radioiodine scan done after a total thyroidectomy.
No, so basic treatment is thyroidectomy. This is
Yes,
my point.
yes.
This is my point. So don't
The
get
treatment, in short, I'll tell you,
Yeah.
after a total thyroidectomy,
Yes.
if you have done a total thyroidectomy for a malignancy, like well-differentiated carcinoma, 4 centimeter lesion, make the patient hypothyroid for some time until the TSS goes about 30, get your diagnostic radioiodine scan. And if you find any thyroid element on the diagnostic scan, then you need to give radioiodine. Why to do otherwise?
No, in this case, Prathamesh Pai said, as patient already has a metastasis, you better give. You know, local
दे बोलने तो
malignancy is different, metastasis is
सर
different.
इसके बात कर
Okay, now we are going to the next case. We have spoken enough on this case.
क्या नाम था इसका?
Ashish, being the maverick genius that he is,
Every day new idea.
every day something new, he has come up with a stereolithography, that is a 3D printing of the lesion which is taken from the CT scan. So from the CBCT, he has actually recreated the skull to create the angiofibroma.
See, this is what material is this? This skull is created from this same patient CT scan. See the technology. This is the 3D technology by means of which the same skull is created of this patient. Whatever anatomy of the skull of this patient is there in my hand, of whose CT scan is here. So this is a 3D technology, 3D printing technology by means of which you can create the 3D skull of that particular patient, so you can understand the anatomy, the bony anatomy, and the anatomy of that particular lesion, how to approach that in that particular patient in your hand. That makes, I am sure that is going to change the life of the surgeons in terms of approaching these lesions with a 3D anatomy in the hand. The same CT scan of the patient, where the lesion is like this, where the lesion is, and how the anatomy is, how the bones are, how can you approach, like in this particular patient. See the lesion. This is just I put to show you. If you see the lesion over here, you can get to know how it is far away from the important structure, how you can approach from the endoscopic, lateral, open, and other approaches. So that's a tremendous advancement in the technology.
This is virtual surgery a la Ashish
Amazing.
Bhumkar. I'm putting this down on record that I find his brilliance amazing. He's an amazing pinna surgeon. I mean, he takes care of a lot of pinnas and all. He's an artist.
Hey, focus on the pinna. Focus on the pinna, boss. You can
Focus
see
on the
his,
pinna. You can see his
reconstructed
artistry
pinna.
there and his genius here.
He has done so many of my patients' pinna reconstruction.
So he is also going to get the ribs printed out so that he knows which are ossified ribs and non-ossified ribs. So he's taken pinna surgery to a new height, And today, I would say I can definitely put down on paper that he's probably one of the top 10 pinna surgeons in the world.
World, yes.
So without a shadow of a doubt. So we are all very, very proud of him.
Yes. Thank you. Proud of you, Ashish. Now coming to the case, is already induced, ready, waiting for us. This is another case of angiofibroma. The lesion is a big one, and what you see on CT scan, the rapid CT, I'll take you just to the relevant findings. The negative part or the challenging part for the endoscopic surgeons in this case is the anterior nasal cavity extension of the tumor. Many of the surgeons around the world who are doing endoscopic angiofibroma surgery would consider this as a relative contraindication to the endoscopic approach. The moment you put your endoscope in the nasal cavity and you get the tumor, you can't pass your instrument or anything, you see the tumor there. So this is one of the relative contraindications, strong relative contraindication to the was considered in the endoscopic approach. And now what you see here, see on the first scan, you see the tumor mass coming so anteriorly. Can you see? Hello?
Yes, we can see that.
See the tumor mass coming so anteriorly in the coronal scans, coronal scan, and now see at the level of the sphenoid rostrum, it is occupying the pterygopalatine fossa.
Infratemporal also, no?
Yeah, it is going in the infratemporal fossa. Now coming to the axial, we don't have a contrast scan. Whatever scan we have got, this is here. See now, compare with the opposite side pterygopalatine, the maxillary sinus. This maxillary sinus wall is pushed anteriorly because of the mass lesion in the pterygopalatine. The classical Hallman-Miller sign. Again, we have a tumor over here going in the pterygopalatine fossa, not very extensively laterally like previous case. It is going there, but it is coming far anteriorly in the nose, and it is a massive component in the nasopharynx as well. See, it is bulging down in the oropharynx over here. Can you see?
Yeah, okay.
So this is the case we have. Now the biggest challenge to us is not the lateral extension you have seen, not the nasopharyngeal extension you have seen, a small component going in the sphenoid also. That is again not a challenge. The challenge is the anterior most extension.
Yeah.
See, you put the endoscope in the nose and you see the tumor. Now let's see how to deal with this. There is some time you need to divide the tumor at the beginning of the surgery to get space for your instrumentation. Yes, not cobbler. I'll use a monopolar. I need a strong instrument if I need to divide the tumor in the beginning. The cobbler may not control the big vessels. This tumor is all composed of vessels. Endothelial line spaces, no smooth muscle, they don't contract. Yes. So let's see after the decongestion how it behaves. In all angiofibroma surgery, our protocol is to give the intravenous antibiotic and steroid at least 3 to 4 days before surgery to reduce inflammation, congestion, and overall vascularity of the tumor. It works very well. I've been doing this for years together, and it works very well to me. So let's see now how it behaves.
आज angiofibroma day है.